Hi, this is Dr. Dan Adair at the Springfield Clinic, Department of Orthopedics. Going to talk a little bit about anterior cruciate ligament. It's kind of been a sexy topic for a number of years here. Certainly been something that I've been interested in for basically 25 years or my entire career. We've been able to go from making this a very elitist operation, or someone who's a very high-grade athlete, to where it's fairly commonplace, and even 50-year-olds will begin to think about having their anterior cruciate operated on and fixed. The primary problem with the anterior cruciate is once you tear it, your knee is okay as a hinge, but it doesn't work well in a side-to-side or a rotational type of activity. So if you cut or turn or just walk on bumpy ground, oftentimes it will quote-unquote give out on you, which is a real problem. In order to fix that, we've got a number of options. Basically, they turn into two options. And my job as a surgeon is to technically do a good operation. One of the things we'll be talking to you about, though, is the type of graft you want to use. And basically, in my mind, the graft itself doesn't make that much difference as long as I put it in correctly. There's a couple suitable grafts that, if done correctly, will give you a nice result. Those graft choices are the kind of the gold standard, which is a piece of the patella, piece of the patellar tendon, right up front here on the knee, and then a piece of your tibia. And that works very well. It's a gold standard, been used forever. We also sometimes will take hamstring tendons from the back of your knee, and those also work very well. Those are both autologous, which means your own tissue. Those have very good results and probably are the most superior way to do it. Now, there is an alternative, which is an allograft or a cadaver graft, which is a very good graft, and there is no donor site morbidity. Now, you'll have to talk with whoever your physician is on the risks of disease transmission, which is very minimal but is present when you undergo an allograft transplantation with a ligament procedure. The nice thing about this is it's very easy, and all of that can be done arthroscopically, and it does keep your repair or your downtime a bit better, and you're able to recover a little quicker. So a lot of times the older people will go ahead and do a allograft because of the quickened recovery period. Plus, as you age, our tissues do get a fair bit weaker. On kids, they typically tend to go for the autograft, and the results are a bit better. As with all this, the rehabilitation is key, and it's about a 6-month deal to go from surgery to return to play. And whether you're a quick healer or a slow healer, it really doesn't matter. It's about 6 months. So you have to be able to do the rehab. It's a progressive thing. Mind your P's and Q's, because of the rehab is just as important as the surgical procedure we do. But most people are able to return to a nice active lifestyle with very little troubles. Although I should say that everybody who tears their ACL presently, the time you tear your ACL, that knee is going to become your bad knee, and is going to get arthritis sooner in it than your knee that you didn't tear your ACL on. There are some programs that can prevent ACL injuries, or not prevent them, but lower the incidence of them. And certainly, if you have any interest in those, you should seek help with your physician as well.